I'm Dr. Jason Beckta, and this is Out of the Basement, a podcast dedicated to practical radiation medicine. Today, we have episode number 2 of a three-part series where Matt and I rant about IGRT choices and various other topics. I will go and upload the figures to Figshare. I don't believe I finished doing that. And then I will also release this on my Twitter, which is at Dr. Beckta. And then I will release episode 3 shortly. All right, so we'll start episode 2.
Well, then that gets into, I love, so now with time-based billing, then, because so this is a great kind of segue to a whole other thing that I'll do at some point, but the things that you think are rules and quote unquote laws in residency are not. And, if you read these regulations, so where a lot of these things come from are CMS. So it really just depends on like what insurance the patient has. So CMS, or the Center for Medicare and Medicaid Services, like they set a lot of the baseline rules, and you could go read, if you just really are bored, you can go read all those for yourselves. But like, what is an actual sort of kind of CMS rule versus what is an institutional policy versus what is a departmental policy versus what is a like who's faculty that day kind of policy. And there's, if you zoom all the way out in terms of, okay, what am I going to do that like violates some sort of state or federal thing? There's very few. A lot of these are just kind of like, left to the discretion of the physician, which is where at least that was the intent. But then it becomes like, what, how many committees can an institution put together to throw up red tape? And then, but, that's the CMS thing. And then there's private payers. And so, Evacor, AIM, UHC, they have their own sort of thing. So, I think for me, one of the things that is hard to adjust to, and kind of when I talk to residents or hear people talk about, or even just faculty who haven't left their institution, like none of these things are like actual laws. And I know we all slip into the word laws, like none of these things are laws. And if you don't leave that sort of environment, you don't know that. And now it was a lot easier, kind of, or not easier, but like it was a lot more apparent 30 years ago, where people forget the NCCN guidelines were only built in 1996. So like pre-1996, there was much less standardization of care, and there was a lot more kind of just cowboy stuff. And now I think with the interconnectedness of all these things and all these kind of guidelines, we start to assume that the way we have to do things, the way we were trained, is just the way it's always got to be. And so, it's interesting when you're talking about kind of going to the, and my reaction to that, for anyone who's kind of like, I think it's totally fine, because I think it's a fluid thing. So I feel bad that you kind of had to get constrained, because like how it works for me is I have kind of set things that I do, but if I feel like something about that patient warrants extra attention, I just say, you need to put this on the schedule and call me every single time this particular patient gets this treatment. So I have the ability to just set that because it's just me. Whereas if you're in a bigger place, you don't get to do that.
Yeah, and I should it should be like, just because I'm sure somebody will listen, I should say that part of that actually came from me, because as like the chief of service, because when we started implementing the 5-fraction sarcoma treatment, I didn't know I couldn't decide really what to do. So part of what's really important, I think, is that it's not, I think the rules are important in that you stay legal, right? Or like stay within the regulations. But I think what's much more important from a new attending or resident perspective is kind of understanding what you're doing with these orders, right? So with sarcoma, it's an interesting situation because extremities are particularly hard to set up. So you kind of want more oversight there. It is a higher dose per day, but the field is pretty big, right? So it's very unlikely you're going to miss. So there's all these like competing factors. And I think my feeling is Cleveland Clinic has it right. I think billing it as SBRT would be the way to go if I had to redo it. But I struggled with this for a while. And admittedly, it was sort of loose, where like if I had a clinic that was doing a lot of them and they did a really good job, I didn't like go to every treatment because I knew they would do a good job. And that part, so.
In an ideal world, that's what happens, and that's a whole other thing. I personally feel like the Livy 5-fraction external beam breast should be billed as SBRT, and I know I'm not kind of ground breaking in that opinion, and we'll see what happens over the next couple of years. But so I guess kind of that part of this was just definite things, that words that you kind of hear bandied about in residency that you might not kind of know. So EPID is electronic portal imaging devices. So This is where it's funny because it depends on the therapist that you work with, like when they trained and worked and stuff. So if you got a therapist who's been doing it for 20, 30 years, they'll be like, okay, port films, or I guess we probably all say that. There are no port films anymore. Like port films are not a thing.
I call them that.
I call them that too. Or I love one of my therapists will come get me and she'll be like, Jason, pre-ports. And so I'm just, what is a pre-port? That's not a thing. But yeah, so the EPIDs have kind of replaced port films, but we still call them port films. So then, the classics for the older ones is 2D and 3D X-ray imaging. So you have KV, MV, and cone beam CT. So it was really interesting because a common piece of advice I got told for interviewing for jobs in residency was like, know the machines that your institution has because you're going to get asked about it. Matt is shaking his head. So I will say, Matt, this actually came up because so in my current department, I have a TrueBeam, like a regular vanilla TrueBeam, and then I have a 21EX. The 21EX only has MV imaging on it, so it really limits what I'm able to do. So I don't have cone beam on that. I only have like MV orthog. So like I don't like to put a lot of things on that I need more delicate sort of precision for, just because MV imaging only shows kind of bones. It's like not great. So to me, like, and I find that very interesting because like if it's in terms of the interview question, in what I was told and what my experience was, it was meant to be more of a conversation where I'm just genuinely curious, but because it actually really affects how I am able to practice day to day. But Matt, you shake your head because it's like scare tactics or what's?
No, I think so. Maybe I misunderstood what you said at the top of that statement, because I think it is important to understand the limitations of the technology, but I don't feel like it's so important, like what brand people have or like, that kind of a thing. I do think that that knowing what the technology is and the limitations of it is really important. I just wanted to slip in something that's pretty funny. So where I trained, they had that Neutron machine. It actually had port films. Like they had they had little cassettes, and they'd like take them out of the thing and run it over to the little film thing. And like, yes, I actually have seen that, which is crazy because I don't know if anyone, like, I'm guessing like nobody has that now or hopefully they don't.
I've seen it I did it in the lab, like during my PhD, because we had those like for certain experiments, but I've never seen that in real life.
Even your 21 EX has a EPID.
Yeah, it's the only thing. So it's got all that. It just doesn't have a KV. If it had a KV image, I would use it more. But when you use those words like KV, MV, MV, those are usually orthogonal pairs, and it depends. You can kind of specify this. So the one thing I've learned, you can do a lot of things, and that's kind of the message of all this is like there's no hard and fast way to do anything, but especially just know that if you're gonna get cute with like certain treatments or palliative stuff and you're not doing cone beams, usually, especially in the beginning for port films, like for however many beams you use, you're going to have that many port films that your therapists need to take. And so like if you're doing 4 or 5 whatever, like in a 3D plan, you're going to go and there's your therapists are going to be doing it for an hour, and then you're going to have like 12 images to review after. And so it does matter. That's where I like to use the dynamic control art.
So I think what's awesome is I think these are great terms, and you have the important concepts on here. And I actually love to teach the kind of the comparison of the KV and the MV, because I think everyone gets this teaching in physics, right? Because everyone sees the graph of the photon interactions, and they understand why MVs are crappy and KVs look much better. Everyone seems to understand the physics of that. What I see people not understanding is how that impacts your day-to-day practice. And so when you're doing a palliative treatment and it's MV only, I tend to tell patients not to get cute with their volumes and have them be kind of generous and have it, you give the therapists space to work, because you can see how hard it is to sort of set up. And I think if you have KVs and cone beam and things like that, you can kind of get a little tighter with things. And I try to drive that point home because it definitely impacts things. One thing I also do is I try to send them to the machine for a very sick patient that's getting like 8x1. And then especially if it might be multiple beam angles, and just to see how long it takes to shoot all of the setup films and all of the port films. And next thing you know, you're like a half hour in, the patient's like complaining and they're uncomfortable. And so I think that keeping that in mind is really important. I laughed before because I've seen attendings that'll do like 4 fields for a spine treatment on a very sick patient, and you can everyone's just like pissed about it. So I feel like it's just important to keep that in mind. And those are things that like you don't think about, right? Because there's a lot of other stuff to think about too. So it's easy to forget that kind of thing.
Yeah, I completely agree.
Cone beams, yeah. I've never seen an MV cone. That's not true.
They exist. Yeah, I haven't personally seen them. I've read about them.
Yeah.
But yeah, no, I think that was the major thing is so MV is easier to see bones. It's just kind of really not great in general. KV is better. Cone beam is just, if you're going to do VMAT, do cone beam, just period. I've seen people not do that. Like, I don't know. I'm sure, now that I said that, I'm sure somebody's going to fight me about that. In my opinion, if you're going to do VMAT, do cone beam daily. That's just me. You do you. But
it depends what you're treating, right? I mean,
so I like it for, well, yeah. So I think it's very important for like pelvis because of bladder and rectum filling. So I don't use it. Yeah. So for me, like
iliac crest.
Yeah. So like, I know I don't like, so I know Simil did that poll about fiducials and cone beams. So I personally, for prostates, I don't use fiducials. I do daily cone beams. I know people who do fiducials, but they'll do like KV. I don't agree with doing fiducials and cone beam. Like, I feel like that's just doing too much. Like, I don't know really what you're gaining out of that. But so for me, because usually I'm doing, so for definitive treatments, which is what I usually do that for. So definitive things in the pelvis, because I always want to see the bladder and the rectum. So whether that's prostate, whether that's like external beam endometrial, like anything like that. For lung, lung is debatable. And I know there's been like this all over on SDN, but like
there's data. Yeah.
I always do daily cone beams for definitive lung. That's
me too, because there's actually data that if you line up to the tumor, like if it's not shocking data, but if you line up to the tumor, then people do better than if you line up to bones, because you'll see on the cone beams that the bones don't line up a lot of days, just because the tumors move around and stuff, and lungs are like crazy. I feel like I'm always chasing tumors around in the lungs. Like
I feel like your practice has been a little bit different, I think, than some of the rest of us. So but it's or at least before now, you'll be kind of here. But yeah, so for I guess to clarify the statement of doing cone beam for VMAT, like, pelvis, because I want to see filling and stuff. And then, as Matt said, for the lung, just because of tumor motion. And then for head and neck, simply because if you're going to do the 3 millimeter PTV margin, like, in my opinion, it's not an option to do cone beam daily. Like, you got to do cone beam daily if you're going to do 3 millimeter PTV margins for definitive head and neck. But
in all those things, you're treating soft tissue, right? So that's the key, is that it's the only way to see the soft tissue. And so when I kind of talk about my imaging choice, I typically kind of try to teach that if you're treating a bone, there's exceptions, obviously. If you're SBRTing a bone, you probably should do cone beam. But if you're treating a bone, like, you can see the bone with MV or KV, and so in that case, it's probably okay. I like the orthogonal pair thing too. Like, I mean, that's, everyone gets that, but I feel like people, we should just be explicit and say that you really need both, because you can't tell that you're in the right place with just one of them.
It's like that meme. Have you seen the meme of like Prince William coming out of the car and why radiologists get 2 views?
No.
I'll tweet that out. So it's a picture. I'll tweet it out later. It's literally a picture of like Prince, one of the British princes. I don't know. He's getting out of a car, and from one angle it looks like he's giving the middle finger, and then from the other angle you see that he's waving. But that's my favorite illustration of that. It's just, it's not. I honestly think it's like psychology, where the human mind wants to fill in the blanks, and it's really easy to see what you want to see in these things. And it's why it's important to kind of just have 2 views, just for safety, because it's just something about the human mind sees this 2D image, and like, you kind of imagine what it is in 3 dimensions, but your imagination is not that good. It's just not that good. It's bad. But really, I think your point about the palliative thing, I completely strongly agree. And I will pick palliative, not so much regimens, but kind of volumes and beam arrangements based on the individual patient factors. And so don't do postage stamp. So I don't know if you use that term, postage stamp fields. Don't do postage stamp fields for palliative, because just don't get cute. But don't get cute. I think that's used derogatorily, in my opinion, by certain kind of people who don't think palliative is worth your attention. I actually think the opposite. I think it's kind of one of the most challenging things we do. But by don't get cute, I mean, don't just say, well, I'm always going to do 4-field, or I'm always going to do this. It's just, there's what it shows you in Eclipse. Like, you can make the perfect, most prettiest sort of Monte Carlo simulation of those pixels, but like you got to look at the patient and say, is this person going to be able to sit on the Linac for, you know, a half hour while I do all my 18 beams? Like that is very, very, very important. Even if it doesn't mean that you have the perfect simulation in your TPS. And then, yeah, this kind of goes, so in the slide, it's more of, I guess this is what we've been talking about, is what type of IGRT do you order? So something that's very frustrating or interesting is now we can go to the NCCN guidelines, we can go to eContour, we can go to everywhere, and it will tell you, like, it's very cookbook. It's just like, all right, if the patient comes in with like this subdivision of this like genetic, mutation of this sort of cancer, this is the treatment you do. But what they hand wave is what kind of IGRT you do. And this is why, so it goes back to like opinions about prostate stuff. Or so I have my way I like to do things. In my opinion, your IGRT choice is really influenced by what you do with this CT sim. And so it's kind of intent and then how you deal with it. So like if you're going to do VMAT and you want to do like head and neck, you want to do 3 millimeter margins, PTV margins, you got to make sure that you, I don't know who's not doing it, but you got to make sure you're doing like an aquaplast mask, and you got to consider if you want a shoulder mask and all these other things like neck extension. If you're going to do something in the thorax, like it's really, it starts at the top. And that's why I think it's probably not included, is that there is debate over what is quote unquote right, but also there's wiggle room in the system. So I don't know if you have ever found anything that tells you what to order, if you just kind of like do it by gut feeling. Or
no, I mean, I have not, so I don't know that I don't know that I've been taught that explicitly. I would say that this comes mostly from the physics department or physics division in our department. They had strong feelings about it. Where they actually didn't was actually with sarcoma. And what was fascinating is I'm a big fan of cone beam for extremity sarcoma because the soft tissue can roll over the bone. So the KV doesn't always ensure that you're setting up correctly. But I've had multiple times that the therapist would say to me, like, I'd prefer to cone beam. Is it okay if we cone beam daily? And then they would just change the order. And then the answer is yes. And I kind of started just ordering it for everyone when they would say that. So I try to listen to feedback from both physics and therapy because they're the ones that are delivering the plan. And so that's kind of where I got most of that from. With lung, I was trained, I guess you have lung as an example here. I was trained to use cone beam and KV. So yeah, do you cone beam and then also KV, or do you just
not routinely? So I guess if it's a VMAT definitive like stage 3 lung, I will just do cone beams. I'm trying to think. There's definitely been instances where I've done other things, but yeah, my default, if we're talking about like 60 gray and 2 gray fractions, I will just do daily cone beams.
So I think I have an opportunity to like hone my practice as I start over in a new department. I was always taught that the reason you do both is because like they'd cone beam, and by the time you're like about to treat, I'm going to step on your toes a little because I know this is coming, but the patient's
do I have it in here? You've looked at the slides more than I have. Okay.
Yeah. So the time, right? So like they can like wiggle around or cough or move between the cone beam and treatment, and so the KV is like a really fast check to make sure that they haven't moved, right? So that's sort of what I was taught, but I don't know if I believe that anymore.
So I don't know. Maybe I do at the other. So I actually did this in my department because I had that question. So on it, and maybe this is later, on average, like for a definitive lung, at least for the couple of patients I was looking at, it ended up being like about 6 to 7 minutes from the time of cone beam acquisition to the last MU being delivered. However, there's a lot of variation within that. So like for one patient, it was a difficult setup day. He was on the table for a total of about 12 minutes from the time of cone beam CT to the end of MU. So that's where, and you can get into the weeds about this, and we'll pull physicists and stuff on here as time goes by. But so there are actually papers on this and about like specifically using backlocks and kind of the error reduction, or error is not the right word, I can't remember, in terms of accuracy. There's a great PowerPoint, I think, from an Anderson physicist, but basically I'll find it. But yeah, so like the using more immobilization, it reduces that kind of intra treatment movement, because that's what really this is all about. There's you got to be concerned about interfraction motion and intrafraction motion. And your choices about immobilization and imaging is really determined by both. And that's why for like pancreas SBRT, I like to do gated imaging. So like every 45 degrees on the arc, I will get imaging and see. So there's a bunch of different ways.
That's like advanced, right? That's like you're getting like really advanced now with intro.
I do. Well, we'll talk about how a TrueBeam can actually do fluoroscopy. So I like to do fluoro on my TrueBeam for my pancreas SBRTs, but that's an episode.
No, but you were talking about triggered imaging during treatment,
Yes.
right?
Yes.
Yeah, that's like even more. It's even more advanced.
That's something else. But these are all the options that people don't really know about, or is not talked about. And I've seen it mentioned on Student Doctor a couple of times. But for what you're talking about is a great point for like lung. So would you pause like halfway through? Like when would you do the KVs?
No. So the standard practice, and like I'm open. I actually would prefer to like hold this practice's feet to the fire, I guess, based on data, is we do a cone beam and then KV and then treat.
I have never heard of that, but that's probably my own ignorance. So it's,
I mean, that's how it was at both. Like that's where I trained, and how it is at WashU also.
See, this is why I love the internet, because there's huge regional variations in practices, and which I don't think people really talk about as much. But so to me, I actually so that's not what I do. But what I would like to do, a variation of that would be so I like 2 arc VMAT plans for like definitive lung instead of like 1 360, or you can do a couple different ways. But if you're doing a like two arcs for a VMAT, do a cone beam, do the first arc, do a KV in between and adjust as necessary, and then do the second arc. That would be my variation of that if I felt like getting super fancy.
Oh, that would make me that would make me crazy, because I'd worry then in the middle that you wouldn't because it's not a cone beam, it's KV.
Right? It's damned if you do, damned if you don't. So it's it's variations of this, the intra, and that's why I like I still haven't figured out how to be able to sneak it into a capital budget. But I'm in a clinic
right now. I'm in a clinic right now where for SBRT they just cone beam. That's it. They cone beam once. To be fair, right, the machine is very close to where I sit, so I'm there in 30 seconds. And
that's my routine. So that's a great point. Sorry, I keep forgetting this. Our environments are very different. I sit like next to the machine, so yeah, I only cone beam once for my SBRTs because I'm right there. So I'm there. Yeah. So
there's actually data in that paper, I think, about the like tele SBRT coverage during COVID. Yeah. I think there's actually data that the time to coverage dropped quite a bit because you like answer the phone and you're right there.
I forgot all. Yes, in the bigger departments, I forgot all about that's an issue. Yeah, so in my department where it's very small, I'm like right there. But I know in the bigger places it's a problem. I would argue, it makes no sense that we have like the physical presence is a very sort of antiquated thing. If you have the ability to just log in on your computer, I would argue very strongly that the ability to remote in immediately far surpasses you standing at the console, because either way the patient is in the vault and you're outside.
You know me, there's I can get distracted 8 times on the way from my
office. I can't believe it.
Like I'll be sometimes they'll text me again, and we actually have a rule that they'll have to recon beam if someone doesn't come, fast enough, which I think is a great rule. I mean, because I
totally agree. Yeah.
As you said, there's like data about the longer time goes on, the more they move around. So I think it's for me is you just it's all like I don't know. I'm very practical about this. I just want to make sure I'm not missing. Right. That's like
that is first principles. Like know what you're aiming at and don't miss. Like that's really our job in a nutshell.
Yeah.
In my humble opinion. So the other thing about deciding about what to order. So there's a trick I like that I learned at my clinic from other docs that I hadn't seen elsewhere. So I will for like palliative cases where I don't want to do daily imaging, first it's a speed component where if I want to do it fast, I'm doing like 10 fractions or whatever, but I don't want to do daily. I will do an IGRT like once every 5 fractions. So I will do like an MV. This obviously if you're only doing 1 or 5 fractions, this isn't necessarily like a thing that matters. But if you're ever doing like a 10, or I guess if I'm doing a 15, then I'm probably going to do more frequent imaging. But for those 30 and 10 cases where you just want to move fast, but you've got so I'll use 30 and 10 for giant fields. So if I'm doing like a giant field, but the patient is in a lot of pain or there's a lot of issues, I will just split the difference and I will do like an MV once every 5 treatments. That's just something so I talked to Evacor about this. So Evacor will deny daily. So if you have a bone met, you cannot order IGRT if the patient has an insurance managed by Evacor. I've talked to them about this where like I've ordered this, like it was 30 and 10. It was like a bone med. There's other ways around that, but it was before I kind of really zoned in. And I told the guy on the phone, I'm like, look, it's IGRT, sure, but I'm only going to do like it in the middle just to double check. Like that's not reasonable to you? Because, oh yeah, no, that is very reasonable. I never considered that, but it's policy. I can't approve this. So it's like, okay.
I've never had so I know this is regional. Like I know that like different practices are not treated the same. But I have never had this problem, and I actually feel like everyone should be daily imaged. There's rare exceptions. I don't think it's bad, right? So it's the statement is not people who image once a week. It's unsafe or anything, but it just seems like these days daily imaging is so in the workflow for most patients that it's like ridiculous to not do it. It's easy to do. It's not like it costs anything extra, and you know the radiation that comes from it is a drop in the bucket. I feel like that we should be able to just daily image. The one place that I think it's not in my routine practice is whole brain. They'll image once a week, but that's like in a mask where, you know, I just feel like I don't.
So it can actually cost more to the patient. You can bill 77 something 14. I can't remember what it is right now. It is bundled for VMAT. You can, and we'll have to double check me on this. There are places, yeah, you can definitely bill daily for imaging if it's not VMAT or IMRT. So it does cost more.
That's okay. So that's fair. I mean, it's not like,
yeah, they bury this because like so for you, like being at giant institutions, this is like hidden behind like a lot of layers. Like so for me, I see this a lot. So but because I strongly agree with you, and this is what I know there was components about APM that people liked, and I like if I had my way, I totally agree. I would cone beam everything all the time. I just think it's safer and better.
but even just KV. I mean, I think or MV. Like I think that, you know, it's funny if you look at these old like safety papers from like the 90s and 80s, the kinds of errors that would happen, you know, they can't happen if you image daily, right? And so I don't understand why, you know, maybe it costs more. I would argue I would be surprised if it costs the patient more because all these treatments are over.
Well, there's charge and reimbursement and out of pocket. Yeah, I don't know.
I think that that it's money well spent. I mean, I just it's weird to me to block it, although it's not like they don't do anything else that's weird and horrible. So
they do. So this is kind of the one last thing. I do feel like, I don't know, maybe my practice is just too small for them to take notice of, because I actually don't get a lot of pushback these days on most things. But the one thing that they still will not do is I don't want to give away like state secrets, but so, you know, there's a way to actually do 3D through Evacor, which, you know, they define as merely generating and evaluating a DVH, which is a crazy sort of line in the sand for them to draw, which we can talk about. But the only time I get routinely denied for IGRT is if it's bone mets. Everything else like is fine, but bone mets is where I get routinely denied by insurance.
So are you still allowed to shoot a portal image then?
Not daily, I don't think.
So like you literally set them up to the skin and treat. That's what they want you to do?
So Evacor defines 3D conformal radiation therapy as generating and evaluating a DVH. So there's a lot of rumors out there, and this actually came from a certain place. But so people seem to think that if you contour like 3 structures, like that's what you need to have to bill for 3D. That's not true. Like it's literally just generating and evaluating a DVH, which every treatment planning software system on the planet right now does automatically. So they want you to bill complex isodose, which with modern treatment technology is actually not a thing we can do. So that's, you know, technically not a thing. But so Evacor managed payers will only reimburse for complex isodose for bone mets. This is a whole other thing, but
you don't get the imaging. I was just looking at the exception because I feel like you could make number one as an argument for like.
So this is just a particular policy. So so you're right, and that's why it's hard to make the general statement. You're absolutely correct. Where it depends on the institution itself, the region of the country, and the insurance that the patient has, because like, so if they have pure Medicare, it doesn't really like that's kind of very different. But you know what, so like a Medicare Advantage plan usually, so like at my local Medicare Advantage plan, there's several of them, you know, but like there's one in particular that a lot of my patients have that's managed by Evacor. And so Evacor is kind of taken over our space a lot. But really, it's reader. So that's why if you're like, or yeah, if Matt and I kind of have different things approved or denied, or you talk to a friend like who says something different, the regionality of it is huge. And you know, it's really, I don't know, it's very confusing, honestly.
Yeah.
Obviously. But yeah, it's mostly so in terms of choosing IGRT, like things to consider. Just you know, there's the insurance aspect of it too, but really speed, how you know. Tight are you getting with your volumes and stuff, but and then for just miscellaneous things, you know, you actually mentioned it earlier, is like what's your match priority? So do you want to like match to the tumor, or do you want to match to like bone? I always, so the tumor is very tricky, you know, depending on the quality. I think you had access to MRI Linux, which I've never had. So I always, well, I shouldn't say always, but I usually will have my therapist first align to bone and then check to make that it makes sense, and then try to align to the tumor secondarily. And by bone, I mean things that don't move. So spine, iliac crest, those sorts of things, not ribs or anything like that. That's usually my general practice, is start with a stable bone and then look and zone in on the tumor. I don't know if you have like a sequence like that.
It depends. It depends what we're treating.
It depends, right? Yeah.
Yeah, we align the tumor is typically what I'll ask for. But you know what's funny is like I'm gonna have to redo this basically in my new job, because there was so much of where I was that was kind of already set, right? And so if I treat a lung, there's like unwritten rules about how those things are supposed to be set up that came from the chief of service and how they've been doing it for years, and I had to kind of adapt to that versus me setting my own thing. So but I would generally have them, if it's a tumor that's visible, I would generally have them align to tumor first and then go from there, I think, if you're doing cone beam.
Yeah, and I think the real message is there's no wrong way. I feel like it's really dogmatic in a lot of places where they're like, you have to do it this way or it's wrong, and that's just not true. Like there's a logic to it, but
you're going to get yourself in trouble in medicine, right? It's like
yeah. But the most important thing is conform to your department first, and then practice medicine. No, I'm just kidding. So, but for the other one, for automatic image registration, I only know how ARIA kind of handles this. So with the ROI box, just pay attention. I've seen people just like not know where the box is and just like try to align to, you know, space and time. I don't know. But so just make sure that and don't make it super tight, like give at least a centimeter or two on either end. And, you know, it really depends because some software, when you change the window, the ROI box responds to what the window is doing versus like a ground truth sort of thing. So know what your software is doing. So you mentioned it earlier, and I do the same thing. I will just grab my physicist and be like, let's go do stuff. And then I will just ask my physicist, just like, is this right? Because that's their job. Like they're better at that than me. So,
Thanks for listening to this episode of Out of the Basement. You can claim CME for this and any other episode by following the link in the show notes. You can find me on Twitter with @DrBekta, or visit www.bektamd.com. If you like this content, please let us know by rating and following us on Spotify or Apple Podcasts. If there's any topic you want to hear covered, or if you want to come on and talk about something yourself, reach out and let us know, and we will make it happen. Otherwise, talk to you next time.